Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more. Hey everyone, I'm the Millennial Mechanical Therapist, and today I want to talk about what you should be doing when things don't go right. As you go through your assessment and everything like that, as you're doing your eval, your exam, your treatment, sometimes things just don't go right, and sometimes you hit a slump. Right now I'm in that phase. About 2 weeks now, maybe a week and a half. Just none of my patients are really responding the way that I really expected them to. So when you hit this point in your career, or one of these points in your career, because I'm sure it happens multiple times, this is really the important time to take a step back and self-reflect on what you're doing. This is not the time to say, well, NDT doesn't work, maybe I should use Graston, maybe I should use Mulligan, maybe I should use Kaltenborn, maybe I should use Maitland. Put anything in there that you want. It's not going to change it. For me, when you're going through this slump, you shouldn't blame the approach, regardless of which one you use. You should not blame that. You should try to kind of look inside first and make sure that you're doing your things right. So a couple cases that I've got right now, I've got a lady with right anterior thigh pain. She came in, on paper looks like a great candidate for mechanical therapy. Her history indicates everything that way. She has a directional preference kind of alluded to in her history, things like that. So as we go through, we check her extension progression, the procedures through the extension principle, eventually end up in repeated extension of the line. We abolish her symptoms, so we get her off the table, but the minute her feet hit the floor, she actually ends up feeling worse in her thigh. Now, with NDT, that's not really something you can do. You can't abolish worse. Those two do not link up. So when you hit something like this, it's time to self-reflect and make sure you're not missing any little things. Make sure you're really doing your job. Maybe as she got up from prone, she lost her lordosis. Maybe she went into a bit too much kyphosis, flexed that, and had a bad reaction to that. Maybe during the transfer she had too much of a lateral component. Maybe she side bent so far, and that kind of brought on her symptoms. Things I probably should be looking for as I'm going through. You need to learn from each case. That's the important part here. Not to say, well, you're not an MDT patient. Maybe I got to do something else. You should take a look at that patient, make sure you're delivering the right things, and maybe it gets to the point where she's not appropriate for repeated movements. Maybe a more of a soft tissue approach would be better. Maybe we're missing the boat and it's actually a hip problem, things like that. But regardless of the problem, I don't think you should jump on the approach you use or the philosophy you use or anything like that first. You should really look inwards and make sure you're doing it right. Another gentleman I have, another case that I'm not really doing too hot with right now, came in with right-sided low back pain. His history also indicated extension responder. But we go through, and I have him do repeated extension and standing. Now, previous to his repeated movements, he demonstrated a movement loss for right side glide with end range pain. As we finished out the repeated extension and standing, we abolished that end range pain with the side glide. So I go, okay, well, it looks like he responds to extension. I checked about 50 reps or so. Every one seemed to be doing the right thing. Send him home with it. Next follow-up he comes in, he goes, I don't feel any different at all, and it actually sucks when I have that roll on my back, that lumbar support. And I go, okay, well, let's check everything out again. Let's make sure we're doing all right. As we go through his movement loss again, he demonstrates a similar thing. He has a demonstrated right side glide loss, and he's got end range pain there. So we go through some more extension and standing. I ramp it up a bit, give him some kind of self-overpressure, do the exhale, and kind of focus in on an object in space, extend as far as you can and then let the head tip back. Give them the overpressure that way. We abolished the right side glide again, the end range pain in the right side glide. So we get that to go away, and I go, try these again. Go a little bit more each time. Put that extra force in it, and I'll see you in a little bit. Have them come back in a few days, and we'll reassess at that point. Now, not everybody's going to be that quick turnaround. Not everybody's going to go bang, bang, bang and be fixed. But anytime you have the slow progression, anytime you hit the slump, it's important to look inside. So with that gentleman, for me, I'm sitting there going, maybe it's an anterior. Maybe I missed that. Maybe I'm reading his history wrong, or maybe I should look lateral a little bit because he has unilateral pain and asymmetrical. So these are all things that I need to look inside at my own clinical assessment skills and my decision making, rather than going, well, he's just not appropriate for MDT. Maybe he is, and I'm missing the boat on it. I'm not applying it right. And I think in a lot of cases, regardless if it's MDT, it's Maitland, it's using Stanley Paris's methods, if it's using Gray Cook's, if it's using Gary Gray, whoever, you can put whatever words, whatever method in there. If it doesn't seem to be gelling with you or working well, maybe you should look inwards first and make sure you're not missing too much. That's what I want to leave you guys with today. Just remember how much that self-reflection really is important. As always, move your patients early, move your patients often, and move them to end range, because that's usually where the magic happens.